series. It's my pleasure to introduce our speaker today, Dr. Jeffrey Petruska. He is an associate professor here at the University of Louisville, shared between the Departments of Anatomical Sciences and Neurobiology and the Kentucky Spinal Cord Injury Research Center. His interesting career path or educational path, he got his BA in psychology from Boston College, followed that up with a PhD from the University of Florida in the first Department of Neuroscience, in the first chartered Department of Neuroscience. After doing some postdoctoral training, he arrived here at the University of Louisville. I've had the pleasure of working with him on a project or two during our time here. And yep, he's here today to talk about understanding neuroplasticity and to treat injury and pain. Thank you.
Good morning. Thank you everyone for coming. Thanks for the invitation. Very much appreciate it. The opportunity. So we'll get started. I understand we have a somewhat tight timeline. I guess this is lunchtime. Do feel free to eat if you have it. A couple disclosures just to start off. I should let you guys know that I'm co-founder of two companies. One is Desense, working on local anesthetics. Actually, Dr. O'Toole is a co-founder as well. I will not be talking about that stuff today. The other one is Pioneer Neurotech, developing nerve repair devices, and we will be going through some of the stuff that is the basic science that led to Pioneer, and a little bit of I'll mention some of the things from them, so I wanted to just disclose that right up front. When I came to the center here, because I really like the idea of a highly collaborative place, and I think that nationally, internationally, places like this and over UK, the Skoberg, do a great job of being highly collaborative. And it's been nice because that same sentiment has been echoed across campus. We have folks that work with a bunch of your BME folks and co-ops, and it's really quite nice. I've enjoyed it a lot. When I went through grad school, this was the sentiment. Do the science, make it good, somebody will take it and turn it into a therapy. What I've come to learn is that sometimes, in fact, most of the time, someone has to include you. And you guys down here in the engineering school may be more familiar with that. That seems to be somewhat of a new concept, some of the med school. But it is growing, and I'm very happy to be part of that and have learned it. This is a little roadmap of what we're going to talk about today. I'm going to start off talking about nerve injury and repair, divert a little bit into neuroma prevention and treatment, because both of those are on the vein of taking laboratory discoveries and doing some design and trying to commercialize them and bring them to the clinic. And I'm going to try and finish with some more basic science that has some promise for looking at tissue damage-induced pain. And if anybody's like, wow, is that connected at all to nerve injury? The answer is yes. Hopefully I'll convince you of that. So just to familiarize you guys, I am a neuroscientist. I comment this, that a fundamental unit is the neuron. You've probably seen this picture or ones like it in the book. Cell bodies, often with dendrites on them. The wire-like portion of those is called the axon. Most, in fact, all axons are encased in, if it's the central nervous system, it's oligodendrocytes. Peripheral nervous system, where we'll spend all of our time here, have a Schwann cell investment. Schwann cells can either myelinate or not myelinate. What we have here is a myelinated axon. So you guys are aware of what a single nucleus looks like. Importantly, for some of the problems that we're trying to overcome, the peripheral nervous system includes the longest single cells in the vertebrate body. You guys may be familiar with muscle cells being multinucleates, but single cell from tendon to tendon. The longest muscle in the body, our body, is the sartorius. You can see here with a little bracket that literally we have single neurons that go from our toe to the base of our skull. Single neuron, one nucleus, one cytoplasm. And so that creates some challenges for trying to do some restorative neuroscience. There are very long structures other than that in the body, such as blood vessels. Importantly, their length is achieved through many cells acting in concert to make a tube. Very, very different deal with the neurons and blood vessels. And you'll see why I bring up blood vessels in a little bit. So peripheral nerve neurons, those cell bodies do not live in the nerve. We're going to talk a lot about nerve injury. Importantly, just so you guys can get a good picture in your head, those cell bodies, nucleus, soma, they do not live in the nerve. They do not live in the target tissue. They live up near the spinal cord or in the spinal cord. So there's a long distance between that cell body and the site of injury most of the time. What does a nerve look like? A little schematic here. So working from the inside out, the most fundamental units, the important stuff in a nerve, is those axons, those single neurons. Those are the wire-like portions, and they're conducting electrical information from spinal cord out or from the periphery to the spinal cord. They're collected up with their Schwann cell investments and myelinated, in many cases, into fascicles, and those fascicles are collected up into a nerve. That's a little bit of what it looks like. Blood vessels are in there, it's connective tissue. It's actually kind of stretchy. The peripheral nervous system is, unlike brain and spinal cord. We have to handle movement. So in regenerative medicine, we can grow ears, livers, kidneys, muscle, all sorts of things. It's really quite cool. But repairing severed nerves is one of the most difficult clinical challenges. We can transplant all kinds of things, but getting the nervous system to reconnect to those transplants is just as difficult. So in many cases, people are looking at partial or complete loss of function, sometimes paralysis, depending on where that injury is. These are very impactful types of injuries. And a lot of folks show up at the neurologist or the orthosurgeon, like, look, can't you just sew it back together? You know, thinking that it's a lot like a blood vessel, and you just can't. So, nerve injury, what are we talking about here? There are many grades to this. You can injure an axon without really disrupting nerve structure itself, and then you can break more and more of the nerve coatings until you get down to the complete transection. And this is going to be our focus right here. So this is a discontinuity, a complete transection of that peripheral nerve. And of the nerve injuries, ones that create a gap are the most difficult ones to treat. So in this situation here is a traumatic injury that destroyed a segment of two nerves here. So this one right here has been cut and a gap was created by the wound. Looks like about a 1.5 centimeter gap here. This is big enough that the cut ends cannot be directly reattached. So there has to be something that's going to bridge that. We hope to get the axons to go from the central side back out to the peripheral and to their targets. So what are the options? An injured nerve here, schematized at the top. Primary repair. This is the #1 bestseller, gold standard. If you can do this, do it by all means. Surgeons are good enough now, they can actually match those fascicles back up on the distal and proximal side. If you get a transection, you better hope that this is what you're gonna, your surgeons can do for you. If there's a gap, and one thing I should mention here is that this repair has to be tension-free. If they have to stretch the nerve to put the ends together, it really does not do well at all. But if there's no tension, it actually does fairly decently. If there's a gap, you have to span that gap with something. The most commonly used thing is just a hollow tube conduit. Next after that is an allograft. So this is a graft taken from some other creature. In many cases, it's a donor from a human. There's some work being done to use animal. And these are decellularized. So all the immunogens have been removed. They're fairly good. Autograft, so taking a graft from another nerve in your body, which is less important than the one that got injured, is also fairly common. So what do these things actually look like? This company Axogen is sort of leading the way in terms of these allografts, decellularized allografts. Their business model is to basically proprietary methods of decellularizing and getting rid of the immunogens and processing these things and making them available for the clinic. And this is probably the most technically advanced nerve repair conduit out there right now. Fairly good, but if you go for, if you have a gap that's over about 3 centimeters, you really start to drop off efficacy, even with these grafts. So anything over about 2.5 to 3 centimeters, in most cases you're going for an autograft. So, sort of summarize the way it is. If you've got different lengths of nerve gap, primary repair is great. Get up to a centimeter, you can pull that without much tension, repair it. Beyond that, you're going to go for a short gap conduit. Beyond that, decelerator is autographed. Anything longer, you can autograph. So, those are your options. Turns out none of them are really, really good if you have a gap. So, all of them have some drawbacks. Some of it has to do with expense, but honestly, the biggest drawback is efficacy. So that gives us quite a bit of unmet need. The longer the gap, the bigger the unmet need. In fact, the prognosis is so poor in patients that have gaps over about 4 centimeters that a lot of them just walk away. Right? Why would I undergo another surgery? Why would I do this when you're telling me I've got a 5% chance of getting this back, and it could induce a whole lot of pain, and it's expensive, and I've got surgery? They just leave. So when it comes to commercialization, this is actually interesting. That's an uncaptured, unknown market, but it's one that can be addressed if we can get something that works up, over 4 centimeters or so. So we talked earlier about blood vessels and how they don't. Blood vessels and nerves are long, but long in very different ways. Those conduits that are the #1 bestseller and the most used thing, they treat nerve repair like blood vessel repair, and it doesn't match the biology. It makes a lot of sense from the surgeon's perspective. Like, just put a tube around it, let it do its thing. Because the peripheral nervous system does have a natural regenerative capacity. I probably should have said that way back in the beginning, but we'll say it now. It does have a natural regenerative capacity, so it can regrow, and it can regrow quite a long distance. What happens after a nerve injury? This first phase where there's actually a little bit of a, if the tissue is either stable or you put it inside of a conduit, there's fibrin, which starts to create some bridge-like structures in between. There's also an accumulation of injury-induced growth factors that are there. You get some angiogenesis and blood vessels that are trying to cross. If the gap is too long, that fails, but the Schwann cells, those protective coating that allow fast electrical conduction, they try to travel along those blood vessels, and then you get some axonal regeneration trying to cross this. And if that works, then you'll get the Schwann cells to actually remyelinate and give those axons back their proper or close to proper electrical conductivity. But if you get something over about 3 centimeters, all of that works for 3 centimeters and under. Over about 3 centimeters, a lot of that stuff just doesn't work very well. So this is sort of the line in the sand, if you will. So in terms of designing things, a lot of people have taken a lot of approaches, and much of what I'm going to talk to you about is not terribly novel in terms of the field, but we got some things right, which is nice. Sometimes you stumble on it, sometimes you screen it, and get some nice things. So one of the most important things is the growth factors. So the nervous system does not need any growth factors to regenerate. It will do it all by itself in a dish without anything. But if you give it growth factors, and the right ones, those axons will grow a lot faster, and a lot more of them will grow. So you don't need them, but they really can enhance the process quite a bit. The question is which ones, and what job do you want them to do? Quite often these devices have some form of shell. In some cases they're solid, and those solid ones, like the collagen ones I showed you up there, are not quite as porous as you might like them to be. This is another big factor right here. A big hollow tube, again, treats a nerve like a blood vessel, but axons don't like that. They really want to have a surface to grow on, and something that's familiar to them. So there are a lot of ways people have tried to offer some greater surface area, structural integrity for these axons to grow into, and you'll see a couple of those. So these are just a few reviews that I threw up, so you can see where the field is going with this. And the field as a whole has been very frustrated with hollow tubes. They're just not working very well. People know that growth factors can help this process, but it's a matter of how do you get the growth factors in there in a clinically feasible way, and a commercially feasible way for that matter. So this is the approach that my colleague, Mario Romero, who's now chair of biomedical engineering at the University of Arizona. A lot of the stuff was done in conjunction with him. And what we have here is a device that combines a mechanical component, or mechanical components, with biological. So it is still a nerve conduit, but it has some additional factors. For one, we add biological growth factors to the mix. They're there to accelerate growth, induce that myelination, and increase the axon population that's actually growing. The other component is that we do have internal channels. They're fairly fine scale guidance, about 200 microns in diameter, much closer to the native nerve. They don't get down to the single axon level like an autograft or an allograft might, but they're pretty good for synthetic. The outer shell has porosity. It's sufficient to allow for nutrient diffusion and for vascular input to come in and actually replace or bring in neovascularization into the center of that very long tube. If you've got a short gap and a short conduit, you can get vascular coming from the ends, as I pointed out earlier. But if you've got a 4 centimeter gap you're trying to cross, you need to get blood vessels that grow into that space directly. So our device allows for that. We have an internal matrix inside that shell. It's an agarose, but it's designed to retain growth factors and be growth permissive, and it's still it's a low enough concentration that allows nutrient diffusion. A little cross section of what that looks like here. So we have a biodegradable polyurethane tube on the outside, and it actually has holes, pores that go through it for that vascular infiltration. 1.5% agarose gel fills this matrix here, and these holes are microchannels. These is actually empty space until they're filled with collagen. And inside that collagen is embedded PLGA microparticles, which are carrying the growth factors. So this is an experiment I'm going to describe where we transected common peroneal nerve in people. It's up here. We didn't actually transect it in people. We did it in rabbits, which are the FDA approved large animal model for nerve repair and the like. So we are doing this in a large animal model. So what you see over here is an intact tibial nerve and a transected common peroneal. 3 separate pictures, but this is the same animal, it's just different parts of the field. So this has been sutured to the common peroneal. It's the middle of it right here. And you can see these little tufts. So this has been embedded for, I think, 3 months, something like that. But what you have here is tissue that's growing into the center of this conduit. This is actually stalks of fibroblast tissue and then also vasculature that's coming in. It's actually quite effective for doing this. It brings the vasculature right into the center of the length. And the distal end also was sutured, and you can see the connection there. All right. So the inclusion of growth factors actually did a really nice job of increasing axon growth through the conduit. So if you just do a standard collagen tube, you get very little. This is the number of axons per channel. There are some, but not very many at all. BNI is a biosynthetic nerve implant. And fill that just with collagen, you get a little bit more, significantly more than just the collagen in a tube, with a collagen hollow tube. But then you add vascular endothelial growth factor or this other growth factor called pleiotrophin, and significantly more. Right? So this is through the conduit. However, if you look at the number of axons that grow out of the conduit, it's not actually that much more than just having standard collagen. So that was a little bit interesting. And to give you an idea of what this looks like, if you put them side by side, this is a hollow collagen tube. You can see that there's an interface here, you get some axons growing, and there actually are some axon cables in here, but very, very few. And you can see some fibrous tissue growing in from the other end. There's just not much going on here. And this is what it looks like in most clinical implants. Fill that tube with collagen. Hey, look, there's an awful lot more going on there. Add some vascular endothelial growth factor, VEGF, a little bit more. Now we turn it into pleiotrophins. This is nice. This is actually starting to get to look like what we really want. And these are 3 centimeter gaps right here. So this is not too bad. Now that's what things look like. What do they act like? So there's a really nifty thing that rabbits do when you sort of startle them and they feel like they're either hopping or they're dropping. They'll spread their toes out to get more surface area. This is a fairly well documented and validated measure, and what it can do is tell you about the motor function going to the intrinsic paw muscles and ankle extensors. So you can see that their paw toes are spread out. This is the baseline before injury. 1 month, the non-injured foot spreads toes. Injured foot, not only there's no toe spread, but there's also no ankle flexion. 5 months after injury, hey, look at that, not too bad. Toes on the injured side are starting to spread out again. So it's a way you can quantify function. So again, this is the same figure that we showed you before. And it looks like the pleiotrophin does significantly improve the function in this assessment. So that's kind of nice. Pleiotrophin by itself looked like it did a pretty good job. It's not perfect, but it certainly did offer something, and it gave an idea that maybe we can add to this. Pleiotrophin is a multifunctional growth factor, and one of the things that it does is it helps with growth a little bit, but it also induces Schwann cell infiltration, and it starts a myelination process. So the Romero lab did a screening, and they did an in vitro screening. This is cultured sensory ganglia. So these are sensory neurons put in culture, and in different conditions. They either gave it glial-derived neurotrophic factor, neurotrophin-3, nerve growth factor, pleiotrophin, or a combination. And it was those combinations that looked like they really started to enhance this outgrowth from these sensory neurons. Again, these sensory neurons, though we put them in a dish, they represent a large population of the axons that would be present in these injured nerves. And so they quantified this. It looked like pleiotrophin and GDNF were really doing a good job of getting these sensory neurons to grow, more axons to grow and grow farther. So that was a nice start. But what about the motor neurons? So they cultured spinal cord sections. The spinal cord is where the motor neuron cell bodies and initiation of axons are. So they put these in culture, same idea, and asked, what happens if we do some combinations? And they borrowed the PTN, pleiotrophin GDNF mixture, as that was one of the best results from sensory. It looked like that was a pretty decent result in motor. So they said, well, let's make this the first pass. This is what we're going to try and do in our in vivo model back in the rabbits. So that's how we got there. And then we went back to the rabbit, used a 4 centimeter gap. This is the one where the efficacy in human really drops off. And it doesn't matter if it's a hollow tube, an allograft, an autograft, 4 centimeter gap makes things start to get really variable in terms of clinical efficacy. So again, proximal side over here, so the nerve is attached on either end of this. This is a 4 centimeter gap. And the conduit is as described before. The only difference between all of these is which growth factor or growth factors is included inside those microparticles, inside the collagen, inside the microchannels. And you can see here that looking down at the pleiotrophin GDNF, there's an awful lot of dense white material. So these are axons that have been myelinated. You can even see some vasculature in there. These are actually blood vessels that have started to run along the nerve just like they used to. This is a really good sign. In terms of numbers of axons taken from a measure inside the tube, this is nice. There's actually not much difference across. That's okay. That's about what we expect, especially from near the proximal line. Now we've left the tube, and now we're sampling from the distal nerve. So this is the axon getting out of the channel, and it looks like we're actually doing fairly decently. Didn't quite reach significance, but there are some more axons there that are looking better. So what about the other measures? Back to the toe spread index, just like we were talking about before. And this control here, which looks like it's very, very nicely recovered. Control is not crushed. This is actually a transection and a direct repair. So there's no gap. And this is actually a nice example. What does it look like if you directly repair the nerve? Hey, it gets an awful lot better. But this is what you're left with if you have a gap. If you have pleiotrophin and GDNF inside of that tube, you do fairly decent. It's 5 months out, put in the functional index, it's not too bad. So we're actually a little bit disappointed. We thought there was going to be a little bit more function with that. We started looking at what exactly is happening there. Is there anything interesting? And you might remember I said that pleiotrophin not only helps axons grow, but it brings in Schwann cells and induces myelination. And when we went to look at the myelin around some of these axons, do a cross-section, you can see them very nicely in EM. We saw that in the pleiotrophin GDNF group, of the treated groups, these had the best axon diameter. So those axons grew out and also increased their diameter. They didn't stay these tiny little thin wisps of an axon. They grew back close to their original diameter, and they got myelinated. And this is a big deal, because if you can myelinate the axons, you don't actually need quite as many to make it across back to the tissue. One of the problems you get in some of the variability that we find is that you'll get a lot of axons that can grow back all the way to the target, but they don't get myelinated, which means structurally they're there and they're connected. You can get electrophysiological responses, but they don't pass their information in a way that's meaningful to the nervous system or the muscles. But if you can get them myelinated, they get back to where they were before or close to it, and it makes sense to the system. So that finishes the basic science that I'm about to transition, but this is part of what Pioneer Neurotech, which I mentioned before, the companies that we co-founded, has taken over and is trying to commercialize. We actually have a STTR funded grant right now to sort of scale up fabrication and validation of a device that does exactly what I just showed you. The growth factor combination I didn't present. It is GDNF plus some other thing. But that significantly improved myelination and function in a 5 centimeter gap in red. So we're really excited about this. You can see the progression from small gap with, add some growth factors. And so progressively we're moving this along. Our best day is not going to repair an 8 centimeter gap. We're not going to be able to do that with this tech just yet. But if the option for a lot of people who have a 5 centimeter gap is walk away, maybe we got something off. So I'm really kind of excited about that. I'll transition a little bit here into this thing called neuroma. Neuroma is this benign growth that happens in nerves. It's an oma of a nerve. And you can get them from any number of different diseases, but the ones we're going to talk about here are neuromas from some form of trauma or damage. So if you get a failed repair, remember I said the peripheral nervous system can regenerate once it's injured. It actually wants to regenerate. It does not like not having a target. And so it wants to grow. So if you get a repair that fails, like the fascicle comes apart and the axons, they, at the micro scale, can't find something to connect to and keep growing, they're going to grow right where they are. And that can actually happen in some of these nerve repairs. It can happen, and I'll show you a little bit of what this looks like. So these are neuromas from a mouse model in which some of the axons in the nerve have fluorescent recorder inside of them, which makes it really nice to see. And this was our ligature that we used to basically mark the end of the nerve. And from different places in that nerve terminus, you can see axons just growing all over the place. And this I love. When this bulge down here, you get this fascicle, and axons are just growing all over the place down here. This is not normal, and these sorts of situations quite often become extremely painful. Anybody who's had a post-surgery neuroma, actually got a good friend of mine who has one of these, and it's excruciating if he hits the edge of his knee. You'll hear some not friendly words, but these are very, very mechanically sensitive, and they can become painful. And the worst part is, it doesn't matter. Every nerve injury will result in a neuroma. They don't all become painful immediately, but at no point in time are you safe. You can have one of these, and 10 years later, it can start being painful, which is really frustrating. This is a little bit of what they look like, sort of just classically. You've got your parent nerve coming in, and you've got this bulb of axons sort of going crazy, trying to find somewhere to go, not nowhere to go. This right here is the newest version of things that people like to implant to try and prevent neuroma. This is great. It's just proved, I think it was a Dutch company, and it's just a cap. It's a nerve cap. And there are a few companies that make these. These don't work very well. Nothing works very well. In fact, there's no standard of care for neuroma right now. There are all kinds of things that people try. Redirecting the nerve in the muscle seems to work fairly decently, but this is so wide open. It was actually these devices that got me into trying to develop devices for the clinic with Dr. Romero. What they did is they actually adapted the very same nerve repair device and those principles that we just talked about, which is how we're going from nerve repair to neuroma, and they adapted those to now try and get the axons to grow into the device and stop in a protected environment. The idea here is this should look very familiar. This is a hard-ish outer shell. It's got microchannels on the inside, and this is agarose. And all of this was designed to get the axons to grow in, just like the devices I just showed you. But then there's a transition, and the agarose increases in concentration. These microchannels are contiguous, but as you go further into the device, you get this gradient. And the agarose is much higher concentration, and you can't get biological factors to go through it. And then there's actually a cap at the end, not that it would matter. The axons tend to grow in, and then they stop, and they just kind of hang out in there. So this is the same device that we showed you earlier. You see those white tracks, those are axons, myelinated axons inside the microchannels of the device. Cutting cross-section, you can see that deep into the device, lots of brown. That means there's lots of axons inside those microchannels. This neuroma prevention device has axons coming in, but start losing that myelination and that thick cable right there. And if you do cross-section, very, very few axons have actually made it far into the device. And there's still more device down here and a cap. So it actually works pretty darn well for getting them inside and keeping them protected. So if you've got them inside this hard shell, we can't turn around and grow back out, and they're protected from mechanical stimulation on the outside. They actually tested this a little bit. These are some examples. So this is axons growing into that device and basically stopping. And if you go and, this is in a rat, in a model called the tibial nerve transposition. The tibial nerve is the one that innervates the sensory, the skin on the bottom of your foot, and it does some of the ankle extensors, so the ones that you go up on your toes. And they take this nerve, they cut it pretty distally, and they transpose it onto the front of the shin. The reason they do that is because you're going to get a neuroma, and poking the neuroma is difficult if you've got soft tissue behind it. And so they put hard tissue behind it. They let the neuroma grow on top of the shin, and you can poke that neuroma against the shin, and you get a really nice response. I think the rat doesn't think it's nice, but it's really easy for us to get these scores, and it's kind of nice. So they'll do a withdrawal, and they'll do a little bit of a lick of their foot, and you can get a pain index. So if you just let a regular neuroma go, stick this tibial nerve on top of the shin, this is what it looks like. It's ridiculous and clumpy, and if you put it inside a hollow conduit, the axons grow in a little bit, but mostly they hang out outside, and they grow their own neuroma outside that tube. But if you put it in ours, which is that adaptation of the nerve repair device, you actually reduce that pain response quite significantly. And so this was the device that got us into actually trying to commercialize and bring things out of the lab and into the clinic. And as it turns out, that one is probably not going to float the company all by itself. And so we're actually back in the lab with that, and we're working on the nerve repair. But that one won't go away. We'll keep that on the back shelf. It'd be very good for an additional member of the portfolio. And what I'm going to talk about now for a little while is tissue damage-induced pain. And the theme here is nerve injury, as much as I talk about tissue damage. Some of these might be familiar to people. Sunburn, big bruise, lots of lacerations, and surgery. So these are sorts of things that obviously do tissue damage. Pain after tissue damage is actually a bit disconcerting clinically. Everybody's heard of inflammation. You can get an inflammation of damaged tissue. It doesn't even have to be all that bad. If you've had a mosquito bite and it's turned red, that's inflammation. We all probably familiar with NSAIDs, Tylenol, things like that, anti-inflammatories. They can actually be very, very effective for certain kinds of tissue damage-induced pain. Anything that has inflammation as part of the pain mechanism, they work fairly well. Problem is, there are some kinds of pain where inflammatories, anti-inflammatories don't work. Even really, really powerful anti-inflammatories and steroids seem to not work. But the tissue is fine. The wound is healed. The surgery is over. Everything looks good. What happened? This is really intractable in many cases, and it's a big problem. So in many of these cases, not all, obviously, it's going to be person by person, case by case, but there are many folks who show up in the pain clinic and they're like, yeah, I had surgery last year. The surgical site or something near it is really, really painful, but the wound is fine. And they often get lost in the medical field because they go back to the surgeon, and the surgeon's like, hey, your wound is fine, I'm done. Go see somebody about your pain, that's not my fault. And probably it's not. Although there are lots of nerves themselves which are cut in surgery, but we're not going to talk about that. This is interesting because a lot of pain clinics, if you're there enough and your pain is intractable enough, they'll try to relieve it with a local anesthetic. And that's great for relieving pain. But the other thing a local anesthetic does is it's diagnostic. If you inject an area of skin that is painful and the pain stops, that tells you that the sensory neurons innervating that skin are required for the pain. That's not always true. Some pain is actually central, and so your spinal cord or your brain has actually taken over the pathology and is driving the pain itself. That's a whole other issue. But if you can drop a local anesthetic into an area that's painful and stop the pain, it says that those sensory neurons are required for the pain. So, perisurgical areas often you can treat the pain this way. It's great for the patient, but it also tells you something about those sensory neurons is different. Something's going on. Right now, this is the way the field looks at tissue inflammation, tissue damage. There are two different things here that they look at for driving pain. There's tissue damage, which they consider inflammation, and nerve injury, right? Damage a nerve. One of the things I didn't talk about at the very beginning of this was the pain aspect, because we're all about the motor recovery and getting things repaired. But when you injure a nerve like that, the sensory neurons, they undergo a big change in the genes they express and the function that they have. They become what's called sensitized. They become more easily activated, and when they're activated, they respond more vigorously. And so if you have a stimulus that didn't used to induce a pain sensation, and now it does, some of that is due to your pain receptors themselves, and they're becoming more easily activated and acting more vigorously. But this is the situation right now. But in a lot of these cases, you can get this pain without nerve injury. It's like the tissue damage, presumably inflammation, is acting like nerve injury pain. What's going on? Right? So these things are there. Let's ask some questions. Does tissue damage alone, no damage to the nerves that supply that skin, induce a persistent sensitization? Right? So this is actually the experimental model that we have. This is essentially a schematized cross-section of a rat without all the guts. The back skin here, we actually do an incision parallel to the midline, but not at midline. And one of the reasons that we do it right here is because we know the anatomy of the peripheral nerves. We're not going to cut a peripheral nerve. And there's a muscle that's underneath the skin. And so this mimics a situation in which you're cutting multiple tissue compartments. You've got epidermis, dermis, hypodermis, and muscle, all in one incision. And that turns out to be one of the better models of post-surgical pain. This is a reflex. I'm willing to bet that nobody in this room has ever heard of the cutaneous truncal muscle reflex. Anybody here have a cat? If you have a cat, I am certain that you have petted it while it was sleeping and its back skin moved. That is this reflex. Horses have a massive one. So if they ever you see a fly land on or something like that, the back skin will move and the fly will go away. Rats and mice have this. Unlike cats and horses, the rats and mice, this reflex shows up only with painful stimulation, noxious stimulation. So you wouldn't know it. You wouldn't know they have this reflex unless you're like me and you poke the back skin of rats. The circuitry for this is kind of interesting. Let's see if we go. So if you give noxious stimulation, the segmental nerves, and these dots are many of the places where you can induce this reflex from. So if you pinch any of those areas on the back skin, you will get this reflex, but it's local, pretty close to where you actually get the stimulus. I'll show you in a second. So activate those axons, the information goes up the spinal cord, motor neurons, and back out to the muscle near where you gave that stimulus. So it's called a local sign. And it's pretty cool. I'm going to show you a little movie of what it looks like. Pinching, skin move, skin move, skin moves. And the focus of where the contraction is moves along with where it's being pinched. So this is what's called a nociceptive specific reflex, and we can use it to ask questions of the sensory neurons innervating the back skin of the rat. So we did that, and we put those marks on the back, and this is one of the places where it's really great to be part of the Spinal Cord Injury Center because we have experts in kinematics. So we recorded this, they wrote a program so that they could actually assess the characteristics of the movement of that skin. And it's nice because it's almost a flat sheet. And so they can, and contractions are more or less linear in parallel to the axis of the animal. So what we did was we said, here's our incision. We're going to stimulate next to the incision. Because axons innervating here probably were damaged or they were exposed to inflammation. And they're going to be the ones that are going to tell us, is there a long-lasting surgery-induced sensitization or not? And we measured these dots. It seems relatively pedantic. It's actually really powerful. So if you do pinch, I should say the pinches were all standardized. So we used a pair of forceps that you could deliver a max pressure with and a max width, and so the stimulus was the same for all the animals in all the areas. So contraction distance, basically, if these two dots were 20 millimeters at rest, how far down did they go? So that if they went to 12 millimeters apart, that's an 8 millimeter contraction distance. And then we looked at the rate, how fast did this happen, because that reflects what was the size of the sensory information coming in, and then the relaxation time, how long did it take to go back to rest? Because you can get actually quite a long after discharge with this muscle. And I've recorded all sorts of things with this muscle, so it's pretty cool. Amplitude definitely increased significantly. I'll take the green off there so we go back. In the injured situation, so when you stimulate near the incision, you get a much greater distance of contraction, much faster rate, and your duration of the contraction lasts much, much longer. So this tells us that this incision actually does induce a persistent sensitization of that system. Now, maybe it was the motor neurons, maybe it was the spinal cord, but probably it was the sensory neurons. And that was, I think, 2 months after the incision. It is completely healed. That wound is fine. But months later, you get these responses. So, well, we give inflammation, anti-inflammatories, they don't really work all the time. And inflammation does not always give rise to persistent pain. But what about cellular stress? What about something like the nerve, or the individual axons that innervate that skin? What if they were damaged? What if there's a cellular stress? A little while back, there was a factor called activating transcription factor 3. It is a transcription factor. This was discovered, cloned, and it turns out it's part of the cellular stress response hub, and it controls the expression of other genes. It's widely expressed in the liver and lots of places. Sometimes it's constitutive. In the nervous system, it's pretty cool. It is absent in neurons that are just standard, intact, naive. You will not find it in the normal nervous system except a few rare places. But the second you injure the axons, you start this process. You get injury signals coming back from the tissue, and the neurons will express ATF3 at a high level, and very specifically. This is a little bit of what the response looks like. So this is the original paper that described ATF3 as an injury response molecule in neurons. And so this is in sensory neurons, dorsal ganglion. Within days, it is very, very highly upregulated. This is in situ hybridization, looking at the mRNA. And essentially, it's an infinite increase in terms of fold change because it's absent to begin with. And so any expression is going to be a high fold change. And it makes a really, really nice signal to noise. Here's the interesting part. After those, they did a nerve crush to do this. This is about the point where the nerve grew all the way back out to its target. The axons grew back to their target, but it stays on. It's at a lower level, but ATF3 stays on. And this, I saw this and I thought, that's interesting, because that says to me that if you injure the axons, they're going to have a long-lasting change that looks a lot like nerve injury. So we actually did a little bit of, and I got onto this because this weird thing happened. I was doing an experiment, and I was looking at ATF3. I was actually trying to replicate somebody else's study. And I did a just staple control. And you get a little bit of tissue damage with just putting staples in. And you got ATF3 in this sensory neurons. I thought, wait a minute, maybe little bits of tissue damage are injuring those individual axons, and it's making those neurons express ATF3. If there are few enough of them, the spinal cord and the brain circuitry will cover up any pain that would happen. You have anti-nociceptive coverage circuitry. And I won't get into that right now, but this could go undetected at the behavioral level, even in us. So we then did a more thorough experiment with this, and we asked, what about other injury-induced genes? We used just a skin incision. Didn't cut any of the nerves or anything like that. And the genes that you would expect to be upregulated as if you did a nerve injury were also changed in the incision side, and quite significant. So then I said, well, what is the clinical situation? Because this is great. However, if we're going to look at the possibility that tissue damage is injuring individual axons, and that could be a mechanism for long-lasting pain that is not inflammatory, we better do what they would do in the clinic. You know, we don't incise skin without anesthesia. If we're going to do it in an outpatient clinic, it's going to be with a local anesthetic, because you're going to go in and block that conduction of action potentials back up to the sensory neurons. So we did that very same thing. We opened up the back skin, and we cut on the right-hand side so that we could gain access, but the right-hand side DRGs would be affected and the left would not. And we anesthetized these nerves here. So they're not conducting anything. In fact, we used a little CCM reflex to pinch and find out what skin was innervated by these now blocked nerves. And we put incisions in there. So the idea here is that we incised skin whose sensory axons cannot send their signals back to the cell body. Turns out that absolutely didn't matter. Those still got ATF3 upregulation. Great, that's pretty cool. We then asked, well, you know, that's great, but axons are often close to an injury. Maybe the inflammation induces ATF3. So let's ask that question. Using the same model system, we could define what area of skin was innervated by which nerve, and we put our incisions just outside of our dermatome of interest. In fact, we left the T11, thoracic 11 nerve. It was conducting and did not have anesthesia. We put our incisions just outside of that. We could define it, again, using that CTM reflex, so we could functionally understand where the axons were going in the skin. And it turns out that you could get up to 1 millimeter. You know, at 5 millimeters, there's no increase in the ATF3. You could get as close as 1 millimeter and still not induce ATF3, even though you're incising skin about 1 millimeter away from those axons. So, skin incision will induce ATF3 in the axons that were cut by the incision, but it doesn't induce ATF3, that injury response molecule, in axons really close. It looks like they actually have to be injured. We actually replicated, after skin incision, this original paper's data, where they did a nerve crush. And ATF3 has the exact same pattern as you would see from over here. So you get ATF3 up and stays up 4 weeks out. We've done it longer, it's up 6, 8 weeks out. It's like it stays permanently. And the wound is healed in there. This is exactly what shows up back in the pain claims. No wound problems, but people still have pain. So we went and asked the question directly of the sensory neurons in terms of function. We injected dye, retrograde dye, into the skin, right there, and we can actually, I'm going to cruise through this, but basically the dye gets transported back to the sensory neurons that innervate that skin. And we pull those out, dissociate them, and we do electrophysiology recording from those traced neurons. And as a control, we used ones that were not traced. And there's a lot of things we measure. But basically what I'm going to show you here is how easy is it to activate them, and when you activate them, what does their output look like? Most of the cases, they're going to look a little bit like this, maybe only 1 or 2 action potentials. If you put in more current, you'll get more action potentials. So in terms of resting membrane potential, they actually became depolarized. This means they're easier to activate. So after the injury, and this is weeks after the injury, the traced neurons became easier to activate. They had a lower threshold for their action potential generation. And this was the big one. So this is called rheobase, input current that's required. Very low electrical input fired those neurons. So it's telling us many weeks afterwards, specifically those neurons, which were traced from the injured skin, we added to that, and we actually did immunohistochemistry on the recorded neurons and asked directly, not just are you traced, but are you traced and are expressing ATF3? And short and sweet of it is that non-injured neurons that did not have ATF3, they were traced. This is what they look like. This is exactly normal. Add a little bit of current, and you're still getting just 1 action potential. Now, if you trace a neuron from incised skin and it has ATF3, this is what you get at those same stimuli. I don't want my sensory neurons doing this. That's going to be painful. That's horrible. That's 100 hertz from these neurons that are not supposed to fire like this. So this was a really, really cool finding. So it looks like everything is expressed in the right place, the right time. This idea that maybe we ought to move tissue damage away from inflammation and move it toward nerve injury, at least in terms of what happens to the sensory neurons. I think tissue damage, much of it, is going to induce injury to the sensory neurons, which is long-lasting, affects their neurochemistry, it's going to affect their physiology. So, just real quick, we asked, can this response be modulated? If you give an incision and just close with staples, and we already talked about that, you get a whole lot of ATF3. What if you glue it instead? This is a common practice of small incisions, and a lot of plastic surgeons use this instead of staples or suture. And it turns out it actually is reduced if you close the incision with glue. And we went further. There's a compound which I'm not going to get into. PC's proprietary compound is not actually proprietary. It's been fairly well used, and it's been used in the spinal cord injury world. It's been used a little bit in nerve repair, and it's essentially a membrane stabilizer. So if the idea is you're cutting these axons in the skin, maybe you give this. We used one of the doses for that has been used clinically, just an intraperitoneal injection of this stuff, and you can reduce the ATF3 expression down pretty low. And electrophysiologically, you change from what would have been a response like this, which would undoubtedly reduce pain, to one that looks an awful lot more like a normal sensory neuron. So with that, I will conclude and say thank you to the postdocs that have been in my lab, Chris, Rob, and Harrison, now off doing their own thing. My collaborator, Mario Romero, working with on that nerve repair stuff and some of the funding pieces. And I'll be happy to take questions. Thank you very much for your attention.
We have time for one or two questions, if anyone has. So the ATF3, why the prolonged presence after the injury? Does anyone know that yet?
Why does it stick around?
Yeah.
I don't know. It doesn't do that in motor neurons. If I showed you that same graph in motor neurons, it goes up, and it comes down, and it basically shuts back. So what's different about the sensory neurons? I don't know, and I don't think it was asked that question. But it's a really good question. Why did they basically go into this new stable state? I don't know.
Does the level of ATF change with repeat injuries at the same time?
Yes. In fact, it is synergistically amplified. I have slides to that effect, but I knew we would get there in time. But yes, that's an outstanding question. There's actually a priming effect, which is common through biology, but if you injure a peripheral nerve, if you do a nerve crush, it'll grow back out at a certain rate. A week later, a month later, come back in, crush that same peripheral nerve, it grows back out about 50% faster. And it's called priming effect. ATF3 does the same thing with tissue incision. So the ATF3 goes up, and then it comes down and stays stable. Do the second incision, and it's like 5 times larger. And we looked at some other nerves that are related to pain states. Things that didn't change with one injury, changed with the second. So there are unique things that changed in addition with that second injury. So that's the point.
Someone has an injury in the nerve, and multiple injuries in the single nerve. It's got like 3 centimeters at some point, and injured at some point, and 1.5 centimeters. And we use the device that basically encapsulates. Can it rework the same way as it was before?
So that's probably one of the most daunting clinical tasks, is a nerve that's been injured in multiple places, because now you've got to span a gap twice. Can they do it? Yes, especially if those gaps are small. So it's all going to come back to the same rules, but the number of axons that are going to make it through the first one to the second one is going to be so low that it's going to be problematic, and the outcome's probably not going to be very good. But it is done. And I think we've got a class coming in very shortly. So thank you very much. Appreciate it.